A case report of bilateral cataract monovision surgery in a 54-year-old lady who underwent a presbyond laser blended vision correction previously. So a 54-year-old woman has come to our OPD who's complaining of diminution of vision in both their since 2 years.
ये देखना इसमें आ नहीं रहा, डिस्प्ले नहीं आ रहा, डिस्प्ले नहीं आ रहा इसमें, इस वाले स्क्रीन पे अगर नहीं है तो इट्स ओके, विल गो टू द अदर्स, देख लो हो जाएगा क्योंकि ये ऑन है पर डिस्प्ले नहीं आ रहा इस वाला, और टाइमर रोक देना, टाइमर रोक दो. Just go to the first slide only.
Yes.
Go back to your first slide. First slide. We'll restart. We'll restart. Okay, fine. Go back to your first slide. Yes. Sure. Yeah, start.
I'm not able to operate from here, sir. I think they are operating.
Okay, let's start.
So a 50-year-old woman has come to her OPD with gradual diminution of vision in both their since 2 years. She also gave the history of undergoing presbyond laser blended vision correction 5 years back. So her uncorrected visual acuity for distance was 20/40 in both the eyes, and for near correction in the right eye was showing N18 and in the left eye it was N5. And on examination we found out that the right eye to be dominant and NCT of both the eyes were 12 mm of HG. So on examination, the patient was orthophoric on the cover test. Extraocular movements were full, free and painless. Anterior segment findings, the cornea, we noted a 8 mm femtolasic scar with a clear interface, and gonioscopy of both the eyes revealed open angles, and pupil was well dilating up to 8 mm. And coming to the lens, she had a posterior subcapsular cataract with a nuclear sclerosis of grade 1, and the dilated fundus revealed a normal fundus. So coming to the pentacam, the K1 of the right eye was 44.3 and the K2 was 44.8, and the Q value is minus 0.48. If you can see the quad map, especially the pachymetry map, the center part of the cornea is slightly steeper compared to the paracentral area. So this indicates that she might have undergone some hyperopic laser vision correction previously. So coming to the left eye, the K1 is 46.4 and the K2 is 47.0 diopters, and coming to the Q is minus 0.69. And in the same, the left eye also, the central cornea, if you see the pachymetry map, it seems to be more steepened than the paracentral area, indicating that she has undergone a hyperopic laser vision correction. So the IOL calculations were done using the IOL Master 700. And we've taken different formulas into consideration, but we went forward with the Barrett Truke TK formula. So monovision cataract surgery with a aspheric IOL was planned for her to achieve a good vision for near, intermediate and distance, and not to induce any new spherical aberrations. So the IOL power that we got was for right eye it was plus 24, and for the left eye it was plus 22.5. A monofocal aspheric IOL, Zeiss CT Lucia, was used for her. First, we operated the left eye and then we have operated the right eye. So a routine phacoemulsification surgery was done using a 2.8 mm incision, and the procedure was uneventful in both the eyes. Post-op period also was uneventful. So binocularly, the patient maintained a distant corrected vision of 20/20 throughout the 6 months post-op follow-up period. So if you can see, these are the refraction that we have got from the post-op period. Binocularly, the patient at 6 months was maintaining 20/20, and the near binocular vision was also N5. And if we come to the Z4 values, it was minus 0.613 in the right eye and 0.483 in the left eye. And the defocus curve coming, it has shown two peaks from minus 0.5 to plus 0.5 with a visual acuity of logMAR 0.0. That means she has a very good depth of field. So using Salzburg reading desk, we have one at 40 centimeters, she was reading 162 words per minute and 164 words per minute at 66, stating that she is comfortable in reading 40 centimeters and 66 centimeters. So the patient was being comfortable with the laser blended vision correction for 5 years. So we have planned the similar thing to be done with the cataract surgery also. So we used the Barrett TK-Truke formula. And usage of aspheric monofocal IOL is done not to induce any new spherical aberrations, because this will, once the new spherical aberrations are induced, this will, whatever depth of field is there for her, it will be not there anymore. And EDOF lens are not suitable in such kind of patients because the retinal image quality will be decreased. So the key thing is always go for a monofocal aspheric IOL to maintain a good distance and a near vision. An appropriate IOL calculation has to be done in patients who are undergoing cataract surgery post-refractive surgery. So in this case, we have chosen a Barrett-TK formula. These are my references.
Thank you.
Thank you.
It was a nice presentation, well presented and well managed case. I just want to ask you one thing, that I mean, most of the things that you presented is now an established fact. So anything new that you would like to convey from your presentation?
What he wants to ask is, why are you presenting this?
Because the thing is that it's a hyperopic LASIK. Hyperopic LASIK, it's Presbyond itself is not done very much. And a patient who has presented a cataract after undergoing a Presbyond, and it's always challenge to calculate and get the correct IOL power, especially in post-refractive, and that's also, it's a post-Presbyond surgery.
Dr. Pragya, did you do you advocate the use of advanced monofocal IOL in such a case instead of a routine aspheric IOL?
No, ma'am.
For a good intermediate kind of vision, because you've not measured intermediate vision in your case. And do you have a pre-operative refractive assessment of the patient? Because you said the distant vision acuity was pretty good. It was
Yes, ma'am.
20/40. So
Yes, ma'am.
and the patient complained of reduction in vision.
Yes,
So did you
yes,
do a
ma'am.
refraction to see if she's improving?
Yeah,
with
we have done,
NS1?
but actually I didn't include in the presentation, but we have
So
done.
was it
yes.
myopic or hyperopic? I just want to know that.
It was
Because with
myop-
nuclear sclerosis, it is.
Yes,
And with the myopic correction, the patient was having N18 vision.
yes, ma'am.
But after surgery with monofocal, she's having monofocal implantation. She's
Yes,
having
ma'am.
N5.
Yes, ma'am.
So how does it
But
correlate?
it's binocularly, ma'am. It's not
No, you
uniocular.
said uniocular N5. In your presentation, you've
Only
written
in-
right eye, left eye, both N5.
Only in the left, that's binocularly, it's near visual acuity is N5, ma'am. But the
But
left eye,
pre-op, it was not N5.
no, ma'am. Pre-op it was not N5.
So it was a myopic error, but the near was not.
Yes,
did
ma'am.
not. Little
Basically, he means to say that maybe because of the
yes,
cataract.
because of
and
the cataract. Yes.
anyways, thank you.
Thank you.
Thank you, sir.
Can you have Shivani Patnaik, please?
Doctor,
Sir, sorry.
sir.
I have to come there?
No, no, no. I don't know.
Shivani, कहाँ से? अच्छा अच्छा, को आता है।
Good morning. Keep it on? Okay, I'll control it, don't worry. Thank you. So this is a small paper on intraop online pachymetry. I've been using this since 2005, so it's not new for me. But we all know that there is possibility of having an online pachymeter in the excimer laser. And it's a direct integration between, it's actually a fiberglass coupling device, which automatically measures the corneal thickness during different steps of laser surgery. So it is a very useful tool, and we'll tell you why. So we did do this 50-patient study in April 23 in myopic and myopic astigmatism. We checked central corneal thickness, compared it with the pentacam, as well as the ultrasonic pachymetry, and calibrated all the devices so that it almost comes to the same. We also did the femto bladeless LASIK flap for everyone between 90 to 110 microns, and this was followed by the laser treatment. We took the online pachymetry reading and did a study on that. The biggest advantage here is that when you open the flap, pre-ablation, you can get a display of the online pachymetry, and that actually tells you the flap thickness. So you can have the pre-ablation flap thickness. You have before you make the flap, you have the corneal thickness. And once you put the flap back and the flap is closed back, you can remeasure at the same time. So this is all the data that you can gather one by one during each step. So it's an online pachymeter which continuously functions during different steps of LASIK. So here we had a mean spherical equivalent between -4 and -3, a mean stromal depth of ablation between 82 plus or minus 22 microns. We had a flap thickness of 90 to 110 microns, and a residual stromal, our target for residual stromal thickness was 300 microns in all eyes. Of course, the optical zone was between 6 mm to 7 mm, depending on the amount of astigmatism, because we know that higher the astigmatism, larger the optical zone, better the outcome and lesser the regression. So here the conclusion was it has a big advantage. Specific features is diagnosis of the thickness of the flap, which is very, very important. Another thing, it's contact free, so you're not touching anything anywhere. Also, individual ablation depth, dehydration effects on the cornea can be monitored, and improved intraoperative safety and quality of LASIK. So in conclusion, having corneal thickness measured continuously is quite crucial. We have this on the Schwinn platform, no financial interest, to assess different flap thicknesses and accurate measurement and depth of ablation during the treatment. So this does work very, very well in our hands. Thank you.
That was really nice and crisp, actually. I just wanted to know whether you have compared it by doing post-op OCT and
Yes.
whether it's comparable.
Yeah, so firstly, I've started this in 2005. So that time, we didn't know what to calibrate it with, and you can have different readings, like you know that a pentacam or an anterion or an ultrasound will not. So first thing is to calibrate all the instruments so that they give the same reading. Yes, there are two main advantages. One, I have done now, because then femto came in, and then we had the OCT, which has come in later. So we have compared, and it's extremely accurate. One more thing I didn't say, because it's a paper, it's a legal document in your hand. So if the patient develops ectasia, so this can come out as a printout from your excimer laser that this was your thickness of the flap, this was your pre-ablation thickness, and after the ablation, this was your thickness. So actually, it's a legal document which can protect you in a later date, which is very, very useful. One more thing I presented in the US long time back is called interface river. So when we put the flap back, and if you don't do the sweep, it has 60 microns of fluid in the interface, which we never knew. So unless we don't do that flap back to align the whole flap back, we never knew how much was the amount of fluid lying there. So these are the other advantages. And some of the centers, use the blade for 10 cuts, 12 cuts. And we all know that each blade gets it, each cut gets it by 10 or 12 microns thinner. And that's another big advantage of online pachymetry. Of course, in femto, we all know that they're all consistently the same, plus or 2, 4, 5 microns. But in blade, it's a big safety tool. So I have a pendulum microkeratome. Many people don't have that. You have the Moria, which consistently does. So it's very useful that, yes, your blade is cutting well, and you can continue to use the same blade in the left eye, or you need to change the blade. So I mainly use it more like a safety tool.
So do you think it will be helpful in LASIK extras?
Of course.
PRK extras?
Yeah. So I've done one very odd out of the box is I did a +9 and I did a LASIK extra on a +9, which is off the record. Patients doing extremely well, but it does help because if the corneas, of course that was a hyperopic LASIK, did well, but if your cornea is a little thin, you can monitor it at the same time. And because I'm doing the LASIK extra in the excimer room, so it does work quite well.
Just for curiosity, I want to know that how much of flattening you could get by doing LASIK extra in that case. Just
So
want to know.
you'll be surprised, sir, that +9 is still emetropic, and now it's more than a year, and there is yet no regression.
No, for +9, obviously you will have a steepening of close to 9 diopters.
Yeah. So he went till about 52. I went till 52. As far as the post, normally cutoff is 51K. So this was correcting 51 point something. Now I'm waiting because it's only 6 months, 8 months old. Now the CXL will start flattening it. So the flattening was, and anyway, flattening will help him to maintain it because that will hold on to it. So idea of doing this LASIK extra was that we hold on to what we have done.
Thank you.
Thank you.
Okay, your time starts now. Yeah.
Good afternoon, everyone. I'm here to present on the topic comparative assessment of the optical quality in small incision lenticle extraction and implantable columnar lens. For the introduction, both SMILE and ICL surgeries are indeed game changers in the world of vision correction. SMILE Pro is a minimally invasive laser procedure that corrects myopia and astigmatism by creating a thin lenticule within the cornea for the precise removal, and it reduces the discomfort post-op. ICL surgery is involving implanting a biocompatible lens behind the iris and anterior to the natural lens, making it suitable for the patients with high refractive errors or thin corneas. This is a reversible procedure which provides excellent visual outcomes for patients who are not eligible for the laser vision correction. The parameters used in this assessment are the modulation transfer function to assess the optical quality, point spread function, and the root mean square values. For the MTF, quantifies how well a system can transfer the different levels of detail or modulation in an image or signal as a function of the spatial frequency. And why it matters? A higher MTF value indicates better visual quality, especially in low contrast conditions. It's important for understanding how well fine details are transferred to the cornea after surgery, which directly affects the sharpness of the vision. PSF describes how a single point source of light is represented in an imaging system, indicating the system's response to a point input and is expressed as a strial ratio. Why it matters? A sharp, well-defined PSF corresponds to clear, focused vision. A broader or more distorted PSF can indicate blurriness or optical aberrations, which can affect the clarity of vision. RMS is a deviation of wavefront averaged over the entire wavefront, and it is the magnitude of the aberrations. Why it matters? The lower RMS values indicate minimal optical aberrations, such as the higher order aberrations like coma or spherical aberration, which typically translate to clearer, more comfortable vision. Higher RMS values could result in glare, halos, or poor night vision. Both SMILE and ICL aim to provide excellent visual outcomes, but the success of these procedures can be assessed more precisely through these parameters. This was a prospective study conducted between July 23 and June 24, and we took a sample size of 50 eyes per group. The parameters were studied pre-operatively and post-operatively at 1 day, 1 month, 3 months, followed up using an eye trace. All surgeries were performed by a single surgeon. The inclusion criteria was corrected distance visual acuity of more than or equal to 20/40, more than 20 years of age, stable refractive error, myopia and myopic astigmatism. For ICL, the minimum anterior chamber depth was 2.8 mm, and for SMILE, the minimum calculated residual corneal stromal thickness were more than 280 microns. In exclusion criteria, any media opacity or trauma, history of previous ocular surgery, dry eye syndrome, glaucoma, pathological myopia findings, retinal diseases, history of prior systemic disease, pregnancy, and uncooperative patient. In the results, out of the 100 eyes, the 50 patients completed a 3-month study. All procedures were completed successfully with no complications. Significant differences were found between the preoperative and postoperative corrected distance visual acuity in the SMILE and the ICL group. In the SMILE group, MTF was lower at 1 month post-op but improved again at 3 months follow-up. And in the ICL, MTF was lower at first post-op day but improved at subsequent follow-ups. In the point spread function, in the SMILE Pro eyes, there was no significant difference at any follow-up. In the ICL group, PSF was lower at 1 month follow-up, but it improved again at 3 months. In the root mean square values, in both the groups, SMILE and ICL, there was significant reduction in aberrations observed at 3 months follow-up. In the conclusion, both SMILE and ICL are effective surgeries in correcting myopia and astigmatism. They give comparative results as per the optical clarity criteria of MTF, PS, and RMS. And though the study showed better outcomes for SMILE Pro at 1 month post-op, but at the 3 months follow-up, both these groups showed comparable outcomes. Both these surgeries have good visual outcomes in quantitative and qualitative terms, and ICL is a better option for the patients who are not eligible for laser vision correction. These are my references. Thank you.
What was the refractive error in both the groups?
So in the ICL group, we took around, for the SMILE group, sir, it was not decided, but if the patient had IMI for more than -6 in ICL.
And in SMILE it was lesser.
Yes, sir.
So did you do SMILE in one eye and ICL in the other eye?
No,
or
sir. No.
the patients underwent?
No, ma'am.
So do you think a high myopia can otherwise also have a little bit different varying PSF and RMS?
Yes,
because of
ma'am.
the
It can happen.
retinal pathology or maybe a little
Ma'am, we don't take patient with retinal
Not
pathologies.
pathology, but yes, due to high
Yes, ma'am, they can differ.
refractivism.
Yes, ma'am, they can differ.
If you then there will be a confounding factor
Yeah.
because if you are comparing two
Non-similar.
techniques, then the baseline parameters should be comparable in the two groups. That is one very important thing. Anything
Yes.
you want to say?
Yeah, I was going to ask the same. So, unless you have your patient data, original patient data, you haven't presented that.
Yes, sir.
So the original patient data, in all likelihood, does not match.
So
In
for
between the two procedures.
Between the
that's
two
what he's saying.
procedures, the same type of patients, the same refractive error, same age groups, all that has to match to be able to compare this. If that doesn't match, this study just says, okay, that Smile Pro is equivalent to ICL. Doesn't mean much as a study. Okay, thank you.
Okay, thank you. Next.
Nasha.
Dr. Nasra Alma.
Yes, ma'am. Yeah. Good afternoon. Today we'll be looking at the visual outcomes of topo-guided laser refractive correction. As we all know, conventional techniques of laser vision correction such as LASIK and PRK have been known to induce or aggravate higher order aberrations leading to photic phenomena such as glare and halos, leading to patient dissatisfaction. Now, with the advent of newer ablation profiles such as wavefront optimized, wavefront guided, and topo guided laser refractive correction, these aim to reduce the induction of corneal aberrations by attempting to create an ideal corneal curvature. The paucity of data on visual outcomes post topo guided PRK prompted us to do this study. We aimed to assess the short-term visual outcomes in terms of visual acuity, contrast sensitivity, and higher order aberrations, as well as assessing the effect of above on quality of life. This was a prospective study conducted over a period of 15 to 18 months, and we included patients with myopic astigmatism aged between 18 to 35 years who also were eligible to undergo topo-guided PRK based on the Allegro Topolizer Vario criteria. All the patients underwent a refractive workup, and the visual acuity, contrast sensitivity, aberrations, as well as quality of life was assessed both pre-operatively and at the third month post-operative visit. We included a total of 88 eyes of 47 patients, of which 51.1% of eyes belong to the 21 to 25 year age group and 56.8% belong to females. Post-operatively, the visual acuity was noted to have a slight decrease, which was although insignificant, could be attributed to the subepithelial haze, which was observed in 4 eyes. Contrast sensitivity, both uniocular and binocular, was noted to have a significant improvement post-op. All the corneal aberrations was noted to have a significant increase post-operatively, except for trefoil, which had a significant decrease. Patients also had a significant improvement in terms of daily activities such as swimming, playing sports, driving, photic phenomenon, and vision without glasses. The visual acuity in our study was in good agreement with other studies, where we found that 95.5% of eyes achieved a post-operative vision of 0 logMAR units. Contrast sensitivity, though controversial in other studies, we have noted a significant improvement both monocularly and binocularly. Similarly, aberrations is also controversial in other studies, but we have observed a significant increase in all aberrations post-operatively, except for trefoil, which had a significant decrease. And this decrease of trefoil was found to be a novel finding. It has not been reported in other studies. Quality of life also had a significant improvement, with subjects giving a mean score of 8.4 out of 10 for vision without glasses post-operatively, and this is also in good agreement. Now, at the end of a study, we had this question as to why contrast sensitivity improved despite an increase in aberrations. We could narrow it down to 4 possible explanations. Firstly, the role of epithelium, where epithelium has been noted to increase considerably, thickness has increased considerably post-operatively, where that could contribute to an increase in the spherical aberrations. However, on the flip side, healthy epithelium has also been known to compensate for higher order aberrations, which might have led to the incomplete treatment of aberrations post-operatively. Second reason could be that the enlarged retinal image, because of disuse of myopic glasses, could also be contributing. Third reason was that there's a complex interaction with the ocular structures, where the positively aberrated cornea could have been negated by the negatively aberrated crystalline lens.
Lastly, the cerebral processing mechanisms could not be assessed as to how a person perceives the image. We had certain limitations, mainly the epithelial mapping was not included as an independent parameter. We have taken only corneal aberrations instead of the ocular aberrations as a whole. Ours was a single arm study and we had a small sample size. To conclude, topo-guided PRK is an effective procedure with significant improvement in visual acuity, contrast sensitivity, and patients also reported feeling more satisfied, happy, and confident with their vision. Thank you.
What was the, how did you decide whether topo-guided PRK will be done or
So based on the US FDA protocol, so there are 3 criteria. We check the patient's manifest refraction and the refraction given by the topolaser video.
Yeah.
So if the cylinder in both the patient's refraction as well as the machine which has given, if it's less than 1.25 diopter, so that is a compulsory criteria which has to be met by all patients. Then we have 2 other criteria depending on their refraction cylinder. If it is more than 2 diopters, then the difference in the axis between the refraction axis as well as the machine axis should be less than 5 degrees. Whereas if it's less than 2 diopter, it should be less than 10 degrees. So that was the
So
criteria.
have you compared it with the wavefront optimized, because it is as good as topo guided in
Ma'am,
the same
actually,
machine? I mean,
yes, ma'am. We have not
what-
compared per se because we wanted, there was no data on how topo-guided PRK was as such. So ideally, we should have compared with the wavefront optimized, but we wanted to see how just topo-guided PRK would be pre-op and post-op.
And any specific criteria for choosing the patients for PRK and not femtolasic? I mean, were they thinner corneas
No, ma'am,
or
nothing
just
like that.
random?
Yeah.
And any refractive error category you have chosen?
Myopic
from
astigmatism, ma'am. So we have taken maximum up to -6 myopia and -3 diopter cylinder.
Did you look at the patient's profile? That is their things like night driving, their
Yes,
profession
sir.
which
Yes, sir.
requires.
Yes.
But that's not mentioned in your slides.
In the questionnaire, I think I have
No,
mentioned.
questionnaire
right?
is
Yes,
fine.
sir.
But did
But,
you make a comparative? I mean, was that a criteria to choose despite having, okay, whatever criteria you have for doing the topo guided is fine. But did you also additionally look at it, or you just randomly went just with the technical criteria?
Just with the technical criteria, sir, we've not assessed it.
Okay,
Thank you.
Thank you. Rishika Annamalai.
My paper is about the refractive outcomes of toric ICL. Myopic astigmatism presents a unique challenges due to its combined refractive components, thereby resulting in compromised visual acuity and patient dissatisfaction. So the toric ICLs provides precise correction of both the errors in single surgical procedure. Aim of this study is to evaluate the visual and refractive outcomes of toric ICL for myopic astigmatism. There is no financial interest. Methodology. It was a retrospective analysis of 125 eyes who underwent toric ICL implantation for correction of myopic astigmatism in a tertiary care center. Preoperative, intraoperative, postoperative data were collected and analyzed. The following assessment like visual acuity, slit lamp examination, corneal topography, pachymetry, individual cell count examination, intraocular pressure, axial length and antichamber depth was assessed in all the patient. After the consent, all the procedures were performed by a single experienced surgeon. Toric ICL power and sizing was calculated using online calculator. The toric ICL was implanted through 3 mm clear corneal incision under topical anesthesia. Post-operatively, ICL position and element were confirmed. Patients were evaluated at 1 week, 6 months, 1 year and annually for up to 3 years. Inclusion criteria. Those with myopic astigmatism between the age of 18 to 48 years with spherical equivalent of -3 to 20 with a refractive cylinder power of up to -6 who had at least stable refraction for 1 year with antichamber depth of more than 3 mm were included in the study. Those who had glaucoma, any corneal abnormalities, uveitis or retinal pathologies with the chamber depth of less than 3 mm with poor compliance were excluded from the study. Results. there was a significant improvement in the mean spherical equivalent refractive cylinder. Also, the mean cadre distant visual acuity pre and post-operatively. Also, the patient had 6/6 vision. It was preoperatively 55% and improved to 89%. The efficacy index, it was 1.2, indicating it was excellent. It had excellent visual outcomes. Regarding the safety and stability, in this study there were no intraoperative or postoperative complications. Endothelial cell density remained within the safe limits with no significant decline. There is no significant changes noted in the antechamber depth and intraocular pressure. Discussion. Toric ICLs effectively correct both the spherical and cylindrical errors significantly. These findings demonstrate this procedure is safe, effective and stable option for correction of high refractive errors. Toric ICLs preserves the corneal biomechanics, thereby reduces the risk of ectasia unlike corneal refractive procedures. It is reversible and can correct high degrees of astigmatism. Conclusion, it is safe, effective, stable. It is a reliable alternative, particularly in patients not ideal for refractive procedures, cornea-based procedures. Precise transformative solution offering long-lasting vision improvement and high patient satisfaction. These findings support its continued use in clinical practice. These are my references. Thank you.
Thank you. It was well presented, I would say. The only thing is that it was a result of toric ICL implantation, which is being done for I think many years. So anything new that you could figure out in this? Any maybe in
thing?
evaluation you can do that. Maybe different anterior chamber depth vis-a-vis requirement of rotation or anything. I mean, something that is new that you could.
So only with the
figure out.
manifest refraction, we were finding whether the rotation was there, sir. Only with the manifest cylindrical refraction, we were monitoring the patient,
So
sir.
how did you check for ICL rotation post-operatively up to 3 years? How did you check?
Only with the manifest refraction. Manifest.
So how many eyes did you have the rotation and required re-rotation?
Nobody required, sir.
Nobody required.
Mostly nobody required, sir. Nobody underwent resurgeries also, sir.
Okay.
For ICL rotation.
Okay. Any okay.
Toric ICL itself is a very stable and very reliable kind of phakic IOL. So
Only
there
thing
is
they complained was initially they had halos, ma'am.
some patients, yes.
Only that they had, and it subsequently subsided also.
We just want to ask anything specific pertaining to toric ICL you want to highlight in your presentation, because this is all pertaining to ICL as well. So anything specific you want to add regarding toricity or maybe sizing relation to the size of the ICL or anything, calculation of the size or anything else?
Did you look for the axis of the IUL after surgery dilatation? You have only written refractive error.
Only within 1 hour in the theatre itself we used to see, sir, in slit lamp. Nothing else. After that we didn't see, sir. That marking we used to see within 1 hour, sir. After that we did not.
After on your follow-ups. 1 month, you have written multiple follow-ups. Any of the follow-ups, the first month or 3 months, did you look at the position of the axis of the implanted lens vis-a-vis the pre-operative axis?
We did not measure properly, sir.
I think that is something that's must for any toric lens.
Okay. Thank you.
Thank you.
Dr. Avni?
A very good afternoon to everyone present here. At the outset, I would like to thank AIOS and APAO for giving me this opportunity to present my work on refractive and visual outcomes of Smile Pro with Vizumax 800. The world of refractive surgery is headed towards flapless surgeries, the advantages being it's less invasive. There's reduced incidence of dry eyes because the corneal nerves severed are less. There's lesser induction of higher order aberrations. The corneal biomechanics are preserved, and it's a single-step procedure that helps enhance the efficiency. So various procedures available with different platforms are all labeled under the umbrella term of KLEX now. So Smile Pro by Visimax 800 is a second generation femtosecond platform that was introduced in 2023. The main advantage being it has a higher pulse repetition rate of 2 megahertz that helps in creating a shorter treatment time of less than 10 seconds, with added advantage of central-aligned system for centration and oculine system for cyclotorsion aid. I would like to mention that I do not have any financial interest to disclose. Its procedure, that is Smile Visimax 500. The other procedures available are Smart Sight by Schwind, AIOS, Clear by Zimmer, and Silk by Johnson & Johnson Elita. Upon literature review, we did not find many Indian studies that are giving the visual outcomes of Smile Pro Visimax 800, and our aim was to assess the same and add to the existing literature. We included 60 eyes of 30 patients above age 22 with compound myopic astigmatism and a spherical equivalent of -4 diopter sphere plus or -1.9 diopter sphere with a maximum spherical error of -7.5 diopter sphere and a cylindrical error of 2.5 diopter cylinder. The corneal thickness was normal in all the patients. We measured the residual stromal bed to be about 300 microns and a normal topography. We measured the outcomes at 6 months and found the residual spherical equivalent to be 0.41 diopter sphere, with 91% of the patients achieving vision of 6.6 or better, and the spherical equivalent to intended target, 71% of the patients were within 0.5 diopter sphere and 100% within 1.0 diopter sphere. The pre-op high order aberrations decreased post Smile Pro from 0.24 to 0.187, and the patient subjectively did not complain of any incidence of dry eyes, glare, halos, or blurring of vision. One complication of suction loss during lenticule creation occurred, which was converted successfully to femtosecond LASIK. Upon comparing our results with other procedures and the latest article by Ganesh et al. On Smile Visimax 800, we found that the visual outcome is comparable to all other studies, the major advantage being the laser and suction duration time, which was significantly less. The take-home message is that in an era where patients are demanding, there are more published literature and comparable reviews are required so that we can offer the best choice to our patients. Thank you.
Yeah, excellent, Dr. Avni. So I would like to ask you, when are you getting your Smile Pro done yourself?
Ma'am, to be honest, it's a priority thing. I absolutely had never had any problems with my specs. They do not even come into my view in day-to-day life. If it would have been a problem, I would have gotten rid of them.
So what do you think is the advantage of Smile Pro over the, like Visimax 800 over Visimax 500?
So Visimax
No
500,
financial
the
interest.
docking time, the laser time, both are more. It's around 30 seconds. And other than that, the review that I did, the visual outcomes are absolutely comparable. The only difference is the laser duration time.
Okay, so what's the advantage of that if you are having Smile Pro?
So
In which conditions?
Smile Pro has a
High power.
visual outcome is the same, to be honest, but for high refractive errors, maybe Smile Pro.
Duration has to do something, no?
Do you think that would reduce the incidence of post-op dry eye or the complication, immediate post-op?
Yes, sir, definitely.
It does.
Yeah.
Why should it do it?
So that
Why it should have lesser chance of dry eye?
no.
Okay, thank you. It was nice presentation. The only thing I want to tell you that you can go through it. I mean, you all are students only. You can always think about what is the advantage of the smaller time, in which conditions, wherein you can have, the advantage of this smaller time.
Off the hand, only glaucoma is the thing I can think about.
One. Yes.
Other than that, uncooperative and anxious patients.
Yes.
That's it. I can't think of any other reason as of now. Yes, sir. I'll go through it, sir.
So you do take patients of glaucoma for Smile Pro, is that so?
Sir, not. We haven't taken any patient till now. Yes.
Okay, thank you.
Thank you, sir.
Palak Gupta. She's not there. Sushant Bhalerao.
Saujanya.
Saujanya, Dr. Saujanya.
Okay, but Palak is not here, right? Palak is not here. Okay. So now we have your Saujanya is presenting,
Yes.
right? Okay. Yeah.
Good afternoon, everyone. I will be presenting the visual outcomes of sterile corneal infiltrates after photorefractive keratectomy. No financial disclosures. Photorefractive keratectomy is the oldest excimer laser-based technique used to alter refractive power of cornea. PRK avoids the production of corneal flap and hence eliminates the potential flap-related complications, thereby yielding safer and predictable results. Though a safe surgery, numerous complications have been reported following PRK, including corneal haze, overcorrection, undercorrection, scarring, regression, and corneal infiltrates. Corneal infiltrates following PRK can either be sterile or infective. As such, this is uncommon complication with fewer reports in literature. The purpose of this study is to analyze the visual outcomes following the successful treatment of sterile corneal infiltrates after PRK with topical steroids. It was a retrospective study, single center study. Records of all 6,280 patients who underwent PRK for myopia and myopic astigmatism between 2014 and 2017 were reviewed, and 14 cases with sterile corneal infiltrate were included in the study. Factors studied are age, sex, time interval between the study and surgery and presentation, visual acuity at the presentation and last visit, location and size of infiltrate, and time for complete resolution have been considered. Results showed mean age is 27.42 years with female predisposition of 75%, and time of presentation following surgery is 3 days plus or minus 1.62 with present pinhole visual acuity at presentation is 0.19 logmer. Blepharitis is noted in 42.9% cases. And characteristics of infiltrate, location is peripheral in 92.86% and central in 7.14%, with the size of infiltrate being 2.07 mm. Follow-up period is around in 64.8 plus or minus 60.36 days, with the time of resolution 8.91 days, with best corrected visual acuity at the last visit is 0.05 plus or minus 0.07 logmer, with scar is noted in 50% cases. We have compared between the fluoromethanol, prednisolone and loteprednol. There is no significant difference in the age, onset of presentation, visual acuity and time of resolution between these groups. The limitation of this study is it was a retrospective study, inability to access the risk factors involved in the pathogenesis of these infiltrates. The sample size for the comparison of outcome between fluoromethanol, prednisolone and loteprednol groups was inadequate. An objective analysis of residual scar formation was not done, which could have helped in evaluating the effect of scar in more detail. Our conclusions are sterile infiltrates following PRK can be effectively treated with aggressive topical steroids, as most of the patients have infiltrates in the periphery of the cornea and resolution takes place with the scar formation in periphery. The visual acuity of these patients remains good in most of the cases. The outcome is generally favorable, doesn't require surgical intervention if treated early. Thank you.
Thank you. That was good. What was the average duration? I might have missed it. What was the average duration of appearance of these infiltrates after
Most
PRK?
of the infiltrates presented within 1 week. Mean average is 3 days.
3 days.
3 days.
Okay. So all these patients were using contact lenses at that time?
Using?
All these patients were
Steroid.
on contact lens, right?
Yeah. PRK, post-PRK.
Post-PRK?
BCL was placed for culture.
Yeah.
No
Okay.
organism has been
Okay. Any scraping was done?
Yes.
Yeah.
All cases, no organism.
And all these patients were treated with steroids?
Steroids, yes.
And they resolved, all the patients resolved completely. So what do you think is the predisposing factor for this?
There are multiple reasons. One is could be BCL steroids causes, like there have been studies with which steroids inhibit cyclooxygenase or pathway that causes more chemoattractants like leukotrienes.
Do you think it has any relation with the pre-existing allergic eye disease? Any correlation between the sterile infiltrates and severity of the allergic eye disease?
Could be, not sure.
You did not.
We have not
assess.
seen.
Was there any difference in the visual outcome finally based on the duration of presentation?
No, only the location, one has central presentation that they had a macular grade scar, so vision was less in that case. Otherwise, in the peripheral scars, vision is good. Thank you.
Thank you. Next is Aishi Mitra.
A very good afternoon to all. I'm going to be present a case on the title, Clearing the Myopic Maze Navigating ICL Complications. High myopia poses challenges in refractive surgeries due to extreme refractive errors. Implantable columnar lens ICL is a novel option for managing high myopia, offering significant advantages over traditional refractive procedures like LASIK, PRK, etc. A 29-year-old female came with complaints of high myopia. Her uncorrected visual acuity was found to be 6/60 in both eyes. Best corrected visual acuity came down to 6/12 with a refractive error of -17 diopter spherical in both eyes. Initially, ICL implantation was performed in the right eye under topical anesthesia. Patient was counseled and topical eye drops were started. On postoperative day 1, patient complained of severely reduced visual acuity in the right eye, limited to finger counting at a distance of 2 meters. Initial symptoms include blurred vision and discomfort. What to do now? So we did a slit lamp examination and optical coherence tomography OCT for evaluation post-surgery. The right eye ICL was found to be mistakenly misplaced, upside down or flipped due to an error in orientation during the surgical placement. OCT macula identified the upside down orientation of the ICL in the right eye, confirming the surgical error. The treatment plan included detailed planning for the correction procedure, emphasizing the need for precision and careful handling. The secondary surgery included the meticulous removal of the upside down ICL. Correct reimplantation of the same ICL with proper orientation was achieved. This is a video of the second surgery that we did. Why is it not playing? So, side puts were made at 12 and 6 o'clock. We did entry at 9 o'clock with the help of a keratome. The upside down ICL was then placed, lifted and placed above the iris. The ICL was removed by the help of IL holding forceps. The ICL was washed and cleaned before injecting. It was then carefully inserted into the injector. It was carefully injected into the anterior chamber from the main wound. Loops were then embedded in the sulcus. Remnant viscoelastic substance were removed. Main wound was closed by suture. And before closing the case, side ports were hydrated. Post-recovery results included a significant improvement in the visual acuity, achieving up to a vision of 6/9 in right eye without the need for corrective lenses. Patient reported substantial satisfaction with visual acuity and resolution of initial symptoms. Key learnings from this case includes patient's counseling is very important before and after the procedure. Before loading an ICL, key points to remember would be verifying the lens power, size, proper sterility, careful handling of the lens, confirming correct orientation of lens using appropriate loading device and technique to safely place it in the delivery system.
Role of advanced diagnostic tools like OCT in identifying and resolving surgical errors promptly. Thank you.
Yeah. So, how do you, suppose you're sitting, you're doing the surgery, how do
Yes,
you
ma'am.
identify whether you're putting it right or not?
Ma'am, like before injecting, the surgeon should.
No. Suppose you've just forgotten. Then on table, how do you identify?
Ma'am,
I
we
mean,
can see
that is
see
the
the
most
vault.
important
The
thing.
vault remains downside.
No, how would you ascertain that the vault is downstairs? Vault is convex. So they have two
Is
boxes.
there something
They
in
have.
the lens?
They have the
Their
yes.
holes are there. Like,
So which is the hole you have to see?
the central
The
hole.
trailing. They are
Trailing
two
the four.
haptics, right? The
हाँ.
leading haptic and the trailing haptic.
Yes,
so how do
ma'am.
you identify? So that is the main thing out of your presentation.
You haven't done
So
this.
do you read
No,
it?
I haven't, and
You
I have
read about
assisted.
it.
Yes, ma'am.
One thing I would want to ask you, you were telling about ICL, but was it ICL or it was some other lens?
Implantable phakicolamar lens.
That was IPCL. So you
IPCL,
had-
yeah.
Because the,
Okay, sir.
the appearance of the lens was not of ICL, it was of IPCL.
IPCL, yes, sir.
So it's better to mention phakic IOL rather than telling ICL, because ICL is again a brand name, right?
Okay, sir. Yes, sir.
And this was not even ICL. So it's better to use phakic IOL in such presentations.
Okay, sir. Thank you, sir.
Sir, we'll close the session.
Yeah. I think all of you presented very well. Presentation was nice, and at your stage, presentation and making slides and your analysis, all those matter a lot, because that gives the impression that you know how to do a study and you know how to present and you know what all things to say. So, whenever you are presenting about any product, you should always write that you don't have any financial interest. And apart from that, you should always try to, whenever you are presenting, try to think that something new has come up or not, or try to figure out something new from it, so that you can always present your case that yes, I found out something new which is not there in existing literature, and this will add information to the existing literature. So that gives more a better impression about the presentation. And of course, the way you present and the analysis and all those things. And as I said, that it was not ICL, it was IPCL. You were presenting ICL. So it's better to use a generic kind of, phakic IOL kind of a. There were other presenters also who were using the trade name. Rather, if you have to, anyhow use the trade name, then it's a different thing. But otherwise, you can always use the overall, like phakic IOL and things like that. And try to get something new from your presentation. That will have a real impact. Anything new. Try to, in your analysis only, try to get something new in that. Even if you get a negative result, you can always say that we analyzed this, we tried to correlate this, but there was no definite correlation. So that will, give a good impression.
Please attend the finals of any free paper. If you attend finals of any free paper, you can know why these papers landed in final, and what was the reason, what is the quality of presentation. Includes the slides, includes everything. Okay, you guys talked very well. Every one of you presented beautifully, as sir said. There is no doubt about it. But the content, there was a lot to desire. Actually speaking, possibly not a single presentation had content which can be even given 50% of the marks. But that is where, if you see a person who has reached the finals of a free paper, any free paper, you understand. You will understand why they have reached, what all they have done, which you need to follow. Once you do that, your presentation will automatically improve.
Deepa, anything you want to say? Thank you.
Okay, thank you everyone.